Hello, everybody. My name is Carlo Di Lorenzo, and I'm a pediatric gastroenterologist working at the nationwide children's hospital in Columbus, Ohio. And it's a tremendous pleasure for me to tape this brief presentation in response to the Torsoli Foundation awarding me the 2021 Aldo Torsoli Award. This is a particularly meaningful award for me, not only because it's named after Professor Torsoli, a true visionary, one of those people who have changed the course of a field of research, the field of gastroenterology and functional GI disorders, but also because on a more personal basis, Professor Torsoli was a very good friend of my father. And by serendipity, I end up being involved in the same line of research and care that Professor Torsoli had. This is a picture of my father enjoying some moments of relax with Professor Torsoli on the beach of Maratea, a place that was so dear to the professor and his wife. My journey, my clinical research and academic journey was not a straightforward one. I graduated in Naples, in Italy, and then I moved to Belgium for a couple of years and eventually went to Los Angeles in California, where I worked with both adults and children with functional GI disorders. Eventually, I moved to Pittsburgh in Pennsylvania. In the past 17 years, I've been in Columbus, Ohio. And throughout all this journey, I found some wonderful mentors that have helped me to become a compassionate clinician and a productive researcher, and have also taught me many life lessons that have helped forge the individual that I am today. And the area that has always had me more passionate about was the one of functional and motility disorders. Children with functional and motility disorders have a great deal of suffering and a great impact on the quality of life. And these conditions are very common. In fact, you can probably hardly think of a child that throughout their life will not eventually have one or more of these disorders, anything from infantile regurgitations to colics to vomiting and dyspepsia and irritable bowel. And these are conditions that are very common throughout the entire world. In fact, if you check countries as different as Saudi Arabia and Australia and Finland, the prevalence of many functional disorders such as functional constipation is very similar. Now, the contribution that I and my co-workers have given to the pediatric literature in the past 35 years have really been focused on three different buckets, right? One is the development of new and more sensitive diagnostic tools. Then the discovery of more effective treatment strategies, and then the increased understanding of the pathophysiology underpinning some of these functional and motility disorders. Let's start with a test that we have helped to develop. The first one is been colonic manometry, a test that was not widely used in the 80s when we, in the early 90s, where we published our first study on children with defecation disorders and the value of colonic manometry to understand the physiology. And now this test has become quite widely utilized in many centers throughout the United States and many centers in Europe as well. We discovered the children after eating and when they're waking up were developing high amplitude propagated contractions, which were responsible for mass movements throughout the colon. We then utilized the intraduodenal manometry or gastrojejunal manometry to better understanding the pathophysiology of children with upper GI tract motility disorders, such as children with chronic intestinal pseudo-obstruction. And we characterize the motor migrating complexes both in healthy children and in children with more severe motility disorders. You can see on the right panel, for example, a child with a severe neuropathic motility disorder. We then try to understand if there were less invasive motility tests, such as EGG or electrogastrography, if those tests could be a substitute for manometry testing, which is fairly invasive in children. And we found out that, unfortunately, no, electrogastrography does not have the same clinical usefulness as manometry testing. And more recently, we have used the wireless capsule, a capsule that you can swallow and then can measure the transit throughout different regions of the GI tract. And we learned that actually this is a technique that has a fairly similar value as gastric emptying scintigraphy studies, and probably even more sensitive than intraduodenal manometry. So more studies are needed to verify whether or not this technique can actually substitute completely the manometry test. We have tried to learn what medications or other interventions can help the quality of life of children with functional and motility disorders. And in the 90s, we used cisapride, which in my book remain the most effective prokinetic in patients with severe motility disorders. We use it in patients with pseudo-obstruction. We then try to characterize the effect of erythromycin as a motilin agonist in children with gastric motility problems. And then we use octreotide, another medications that, differently from erythromycin, which works on the stomach, octreotide we learn works in improving small bowel motility. We also try to study the effect of medications on the colon, and we learned that bisacodyl actually induces high amplitude propagated contractions. That's the mechanism by which it acts as a laxative. We more recently have learned that augmentin, an antibiotic, is actually a very effective motility agent for the small bowel. And even more recently, we published our experience by using pyridostigmine and other motility agents in children with generalized motility disorders. But we have not just used medications, we have actually developed a very active neuromodulation center in Columbus, Ohio, in our center at Nationwide Children's Hospital. And we have developed the largest pediatric experience by using gastric pacer. And we have studied children with a variety of different conditions, and we have very recently published our 10 years experience. And you can just look at the last bullet point. We have actually learned that the children with severe nausea and vomiting, when treated with the gastric electric stimulators, improve the symptoms and the quality of life, and often actually are able to transition from tube feedings or parenteral nutrition to oral feedings. We've also used the sacral nerve stimulator, another invasive way to try to normalize defecation disorders. And this is our experience in more than 60 children receiving this device. We have learned that although constipation may not necessarily improve, fecal incontinence does. You can see in the bar graph that after 60 months of treatment, about 60–70% of children go down to having less than one episode of fecal incontinence per week. We've also developed a multidisciplinary center for the rehab of adolescents with rumination syndrome. This is actually an endeavor that makes me particularly proud. We published our experience, and we have learned that the vast majority of adolescents with rumination syndrome may actually completely overcome their problem after a few days of multidisciplinary treatment. And we have treated children such as this adolescent girl that went from having a need for a nasojejunal feeding tube to be able to eat a burrito at a local restaurant in a few days. And actually, she sent us a very nice email here saying that incredible, she was thrilled about her improvement. Finally, We, with our group, we have advanced the understanding of functional GI disorders. We published our experience in the 80s when I was still in Naples about the function of the esophagus in children with gastroesophageal reflux and esophagitis. We have then published our case series in children with post-viral gastroparesis, and then in children with post-infectious functional gastrointestinal disorders with a multi-center experience. And actually, we've been among the first to use the gastric and rectal barostat to understand visceral sensation and detect visceral hyperalgesia in children with functional abdominal pain and irritable bowel. All these contributions have led me to one of the most satisfying aspects of my career, which is being part of committees and working groups to clarify and coming up with guidelines on a variety of functional disorders, from functional abdominal pain, from functional constipation to intestinal pseudo-obstruction, and even coming up with a terminology and definition of colonic motility in children and adults with who need such studies. And that's led me to be part of Rome. I'm very grateful to the Rome Foundation that asked me to chair the Rome 3 and Rome 4 committees, and this is the group that work in the Rome 4. The first one was about having dinner, and this one being hard at work in coming up with improved criteria for Rome 4. It was not only the improved criteria, but we published the current understanding of functional GI disorders in gastroenterology and a variety of other products such as books, slides, and other algorithms to help the care of children with functional and motility disorders. So I want to really give another heartfelt thank you to both the Aldo Torsoli Foundation and the Rome Foundation, who deemed me meritorious and worth to receiving this award. Thank you so much for asking me to give this presentation.